I think one of the more challenging areas in terms of cancer care is care of a patient with a head and neck malignancy. And again, I am very pleased to have one of the top experts in the world, Dr. Barbara Burtness, joining us from Yale Cancer Center to discuss some of the specifics related to this particular group of patients. Dr. Burtness?
Thank you, Haas. I did break the rules on slides because I wanted to share this website. globalsurge.org has now started a registry called Cancer COVID Surge. And I think particularly in head and neck cancer, this is going to be extremely important for people to participate in and track the outcomes of the different mitigation strategies that people are taking. I think people on the phone may be aware that COVID viral load is the highest in the nose and the mouth. I mean, that the loss of smell, the loss of taste, the acquisition as a respiratory airborne virus. So the risk to healthcare workers from aerosolization from any procedures in the nose, the oral cavity, the pharynx, the hypopharynx is extremely high. And there are reports of extremely high transmission of COVID to healthcare workers, specifically from ENT procedures. There's one case of a benign sinus procedure where 16 out of 16 people who were in the operating room for that procedure converted. So there is great sensitivity on the part of our surgical colleagues to using surgery appropriately and doing it when it is life-saving and when there are other strategies that are also quite likely to lead to disease control that would be lower risk to consider those. It's also the case that given the personal protective equipment requirements of having people in the operating room for a head and neck procedure, these procedures are going to draw a lot of resources. Surgical reconstructive approaches after head and neck surgery are phenomenal nowadays, but these can be very long operations with very high blood transfusion demands and very long post-operative hospitalizations and even long post-operative unit stays. So in our current resource environment, these operations are problematic. So the nature of this registry is that if you assume that there's a pool of patients awaiting head and neck surgery, some have elective operations, some have emergency surgery because their airway is going or they're bleeding, but many may have delayed surgery, atypical neoadjuvant treatment, or indeed non-operative management, and they want to collect the data. There's a similar database that's being set up to look at outcomes from alternate radiation and chemoradiation strategies that there was an international call about yesterday. So I do think that people are tracking these data. I know that the group at Milan already has a 600 patient database that we're going to be able to refer to. So just in terms of what happens when our patients come in, we continue to rely on our multidisciplinary tumor board to figure out what are the operative or non-operative strategies that a patient needs. If we're doing something non-operative that involves induction therapy, we're staying away from the tried and true TPF regimen because that has a very high rate of neutropenic fever, even with growth factor and prophylactic antibiotic support. And we want to keep those patients out of the hospital and we keep them from being profoundly neutropenic. So at our institution, we've moved to the old ECOG regimen of weekly carboplatin, paclitaxel, and cetuximab, but there are other less intense induction regimens out there that others are using. When we do combined chemoradiation, although there's overwhelming bulk of the data are behind the use of high-dose cisplatin. That is a regimen that results in more hospitalization, more renal dysfunction, and we are concerned that hospital resource utilization, the risk of nosocomial infection, and in fact, as we were hearing from Dr. Manley earlier, the possibility that if you develop COVID while you're experiencing renal failure, that your outcome would be worse. For all of these reasons, we've moved away from high-dose cisplatin towards either weekly cisplatin or a carboplatin-based approach. As you heard from a lot of the other diseases, We are still continuing to use immune checkpoint inhibitors. There was an early concern that this might be something that would lead to worse outcomes for patients because they might be at higher risk for the hyperinflammatory state, but we have not really been able to get data from either European colleagues, and I'm curious to hear the later segment of this webinar, what people feel, but we've been continuing to use the IO agents and moving pembrolizumab to the 6-week schedule that's been approved in Europe. We do a lot of hydration for our patients on cisplatin. We're trying to set that up for home to minimize their time in the center. When we have patients who are in complete response on immunotherapy, the standard of care has been 2 years of treatment. There's never really been any discussion about whether we ought to study 12 versus 24 months, but we've been much more likely to discontinue IO in patients who are already well into a complete response. In the postoperative setting, our patients have about an 8% benefit from the addition of chemotherapy, but it markedly increases complications and risk of hospitalization. So we are reserving the chemo for the most egregious cases, the most gross extranodal extension, and the patients with positive margins. I want to say a word about the fact that head and neck cancer patients, that we have these two groups, the HPV-associated cancers where prognosis is usually very good, and the HPV-negative population where socioeconomic status is lower, education is lower, and this is a group of patients who've often been relying on others for rides. Our volunteer ride service is fraying a little bit, and they actually have been kind of hard to convince about the importance of hand washing and social isolation and so forth. I think they just had been a little bit less aware of what's going on. So we've had to do a lot of extra education for them in that setting. So thanks.
Thank you, Barbara.